Hi, my name is Sydney Levine, and today I'm going to be answering Case Connections 3 and 4. The scenario of Case Connection 3 is a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn, and urinalysis is performed. The first question states, what is the best explanation for the presentation of gout in this individual? Please explain why the other choices are not consistent with the data or what additional information you may need to decide the root cause. So, my response is that the most likely explanation of gout in this individual that was presented, based on the results of the patient's urinalysis, is the reduced urinary excretion of uric acid. The rationale behind this choice is that elevated levels of urate in plasma and lower than normal levels of uric acid in the urine are unlikely, since the clinical manifestations of these deficiencies do not match the symptoms observed in this patient. There are several potential deficiencies of purine salvage pathways, such as Lesch-Nyhan syndrome and adenine phosphoribosyltransferase deficiency. Lesch-Nyhan syndrome is a rare genetic disorder that is inherited in an X-linked recessive manner, meaning that it overwhelmingly affects males, while females are the carriers of the defective allele. This syndrome is characterized by the functional deficiency of hypoxanthine guanine phosphoribosyltransferase transferase enzyme, also known as HPRT. HPRT deficiency leads to the dysfunctional hypoxanthine and guanine salvage pathway, which results in the degradation of these purines to uric acid. One of the main reasons why this patient is unlikely to have the syndrome is its clinical timeline. The disease usually occurs between 3 and 12 months of age. It rapidly progresses to CNS abnormalities, such as intellectual disabilities, spastic paralysis, movement control abnormalities, and altered behaviors, often resulting in self-harm. None of the symptoms are obvious in the patient. Another example of the purine salvage pathway deficiency is adenine phosphoribosyltransferase deficiency. This genetic disorder is inherited in an autosomal recessive manner and impairs the ability to salvage adenine, which results in the accumulation of adenine and its oxidation to 2,8-dehydroxyadenine. The latter can cause a variety of neuropathies, which is not observed in the patient, at least at the moment. In addition, patients with this genetic anomaly usually have normal serum levels of uric acid. The deficiency of the purine salvage pathway and the overproduction of purines essentially result in similar metabolic outcomes, since the immediate effects of both abnormalities are increased levels of purines in the blood, which, in turn, leads to the increased production of uric acid. Uric acid is normally eliminated by kidneys, and in case of either purine salvage pathway deficiency or purine overproduction, it is conceivable to expect increased levels of uric acid in the patient's urine, which are not observed in this case. The scenario continues with, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you that he drinks between 4 and 5 liters of soda a day. The question asked from this information is, what is the potential impact of this dietary modification on the presentation of gout? And my response to this is fructose, the main sugar found in regular soda, is metabolized in the liver. One of the byproducts of fructolysis is uric acid. Therefore, consumption of high amounts of fructose results in elevated uric acid production and increased levels of uric acid in the serum, which is a known risk factor for gout. And this explains how the reduction of daily fructose intake can reduce gout symptoms in the patient. Now, for the case connection 4, the scenario states, a 58-year-old woman presents to the emergency department with progressive fatigue and weakness for the past 6 months. She is short of breath after walking several blocks. On review of systems, she mentions mild diarrhea. She has noted intermittent numbness and tingling of her lower extremities and a loss of balance while walking. She denies other neurologic or cardiac symptoms and has no history of black or bloody stools or other blood loss. On physical examination, she is tachycardic to 110 beats per minute. Other vital signs are within normal limits. The head and neck examination is notable for pale conjunctiva and a beefy red tongue with loss of papilla. Cardiac examination shows a rapid, regular rhythm with a grade 2 out of 6 systolic murmur at the left sternal border. Neurologic examination reveals decreased sensation to light touch and vibration in the lower extremities. No depression noted. The hematology consultant on call is asked to see this patient because of a low hematocrit level. Megaloblastic anemia is suspected. The first question asked is, which of the following vitamin deficiencies is the probable cause of this presentation? My response is, the most likely cause of the patient's symptoms is vitamin B12 deficiency. Vitamin B12 is known to be essential for the proper maturation of red blood cells, and the finding of megaloblastic anemia strongly suggests the aforementioned diagnosis. Abnormally large red blood cells observed in megaloblastic anemia usually have incompletely developed cellular contents, and this contributes to their reduced ability to carry oxygen. And in addition to this, the abnormal red blood cells in patients with megaloblastic anemia have a shorter lifespan than normal red blood cells. Functional impairment of red blood cells results in reduced oxygen carrying capacity, or RBCs, which explains reported fatigue, weakness, and shortness of breath. Other patient symptoms that are concordant with vitamin B12 deficiency are pale conjunctiva and a beefy red tongue. Neurological symptoms that the patient reports, such as tingling and numbness in the lower extremities and loss of balance, are characteristics of B12 deficiency as well. Anemia that is caused by the deficiency in iron supply usually manifests as fatigue and weakness, but it doesn't show neurological impairments observed in the patient. A deficiency of vitamin B6 can result in anemia, but of a different type, microcytic anemia. And taken together, patient symptoms point to vitamin B12 deficiency as the most likely cause. Now I'm going to discuss how this vitamin deficiency impairs purine or pyrimidine metabolism. Vitamin B12 is the essential cofactor for the enzyme methionine synthase, which is responsible for the conversion of the amino acid homocysteine to methionine. And vitamin B12 deficiency results in the failure of this reaction to proceed and the subsequent increase in the serum homocysteine levels, as well as the deficiency of amino acid methionine. Homocysteine and methionine are key elements of the methionine cycle, which is intertwined with the folate cycle, which is required for the synthesis of nucleotides. 5-methyl tetrahydrofolate, an element of the folate cycle, serves as a carbon donor for methionine synthase. Vitamin B12 is also essential for the conversion of methylmalonic acid to succinyl-CoA. Accumulation of intracellular methylmalonic acid inhibits methionine synthase activity, and together with increased intracellular levels of 5-methyl tetrahydrofolate, decreases purine synthesis. And here are some potential laboratory findings and tests that assist in my differential. The following laboratory tests may assist in confirming the aforementioned differential. Complete blood count with peripheral smear should confirm the megaloblastic anemia. The serum vitamin 12 levels, if reduced, would support the hypothesis of vitamin B12 deficiency. In addition to that, elevated serum levels of homocysteine and methylmalonic acid can serve as an additional confirmation of the vitamin B12 deficiency.